the case definition as per WHO protocol. So as per the WHO protocol, there are two types of dengue. One is probable dengue and another one is confirmed dengue case. So what is a probable dengue? A patient with a history of fever, duration ranging from 2 to 7 days, along with retroorbital pain, headache, right, mucosal bleed, or arthralgia, thrombocytopenia or leukopenia. Along with that, these patients, along with their blood test is positive for NS1 or IgM antibody in dengue, but non-ELISA based rapid diagnostic kit method, right? So this is a case definition of probable dengue. That means the blood sample is positive for NS1 or IgM, but that is in non-ELISA based rapid diagnostic kit based method. But what is a confirmed case of dengue? So along with these symptoms, if the sample is positive for IgM or NS1 antibody in ELISA based method, or RT-PCR positive for dengue, or the viral culture isolates the dengue virus. So this is the case definition. One is probable dengue and another one is confirmed dengue fever. What are the, this is a very important slide. You have to remember point by point. Okay. So what are the warning signs of dengue? This is the latest, as per the latest WHO guideline 2009. One is the patient, if the patient is having abdominal pain, severe abdominal pain, persisting abdominal pain, persisting vomiting, that means the episodes of vomiting is more than equals to 3 episodes per hour, or more than equals to 4 episodes in 6 hours. So this is called persistent vomiting. Or any bleeding manifestations, or the patient is lethargic or unconscious, patient is having hepatomegaly, that means more than 2 cm liver span below the costal margin, or in laboratory wise, if the hematocrit is more, or the patient is having ongoing thrombocytopenia, severe thrombocytopenia. So if, or the most, and another one is clinical fluid accumulation, that means serositis, inflammation of the serosa that leads to pleural effusion or ascites. So if any one of these warning signs is present, then this is defined as moderately severe dengue and you have to admit that patient. Okay. So remember these things, these points. This is very important. So now regarding this is the classification of WHO severity of classification of dengue, that is divided in 3 segments. One is mild, that is group A, moderate group B, and severe group C. Group A, that is mild, as per the definition is concerned, that means the patient is only having fever, no warning signs or symptoms. These kind of patients can be managed well in your home, okay, just by adequate fluid resuscitation and controlling the fever. Second one is moderate dengue, that means group B, that I have already discussed about the warning signs. If the patient is presenting with fever along with any one of these warning signs, this is called moderate dengue. You have to admit that patient, mainly in IPD but not in ICU, in ward only, okay, just do a supportive care. And last one is severe dengue. Previously it was called as DHF or DSS, that means dengue hemorrhagic fever or dengue shock syndrome, but all these 2 entities are now covered into one entity, that is severe dengue. So severe dengue is defined as severe plasma leakage that is manifested by dengue shock syndrome or hematocrit rise, hemorrhagic conversion, that means dengue hemorrhagic fever, any kind of mucosal bleed or non-mucosal bleed as well, hematemesis, hemoptysis or hematuria, and the patient is presenting with severe organ impairment. That means maybe transaminitis or hepatitis, SGPT, SGUT is more than 200, or AKI, acute kidney injury, or CNS manifestation in term of encephalopathy, or cardiac manifestation in term of myocarditis, right? So all these things falls into category of severe dengue. So you have to admit this patient in IPD and preferably in ICU setting. So this is the WHO criteria for severe dengue. As I have already mentioned, severe plasma leakage, that means dengue shock syndrome. So that is manifested as tachypnea, tachycardia, and why pulse pressure is narrow, and the blood pressure also, systolic blood pressure is less than 90 millimeter of mercury, or diastolic blood pressure is less than 60 millimeter of mercury, and most importantly, mean arterial pressure is less than 65 millimeter of mercury, along with tachycardia and the narrow pulse pressure. So this is a definition of dengue shock syndrome. Second one is respiratory distress in form of ARDS, acute respiratory distress syndrome, or pleural effusion. And third one is rising of hematocrit more than 20%, or PCV, packed cell volume, more than 20% from the baseline. So why this hematocrit is rising, and why we are concerned more about hematocrit in case of dengue? Any idea? I have already mentioned in my previous class, in my pathogenesis class. So any idea why hematocrit is rising? Why we are bothered so much about the hematocrit and platelet? So because, dengue is a viral disease, you all know, but more than a viral disease, there is a cytokine storm happening in dengue in some kind of patients. So that means there is cytokine surge, increased number of interleukin 6, TNF alpha, and interleukin 1 as well. So all these cytokines makes the capillary leaky by interfering the glycocalyx formation. So if the capillary is leaky, then the plasma is leaking out from the vessel. So that's why, suppose there is a bucket, right? There is a bucket and there are some pebbles inside and water full of it. So the pebbles is hematocrit and the water is plasma. So if there is a leak just beneath the bucket, what will happen? The water is leaking out, but the pebbles are inside that bucket. So the density of the pebble is more than the previous one. So that is why hematocrit rise. That means the patient is having severe dengue, severe organ impairment, and severe hemoconcentration because of the plasma leakage. So this is why we are more concerned about the hematocrit. And just along with that, we are concerned about the thrombocytopenia itself. Why? Because why there is a platelet decrease of platelet in dengue? One, because of this cytokine storm, there is bone marrow suppression that leads to transient bone marrow suppression that leads to thrombocytopenia, and in case of severe dengue, maybe the thrombocytopenia is because of the DIC, disseminated intravascular coagulopathy, right? So severe plasma leakage. Next one is severe hemorrhagic manifestation. Maybe the hemorrhagic manifestation starts with only a minor mucosal bleed, but if you are not concerned enough, that mucosal bleed may lead to severe hemorrhagic transformation, such as massive hematemesis, hemoptysis, hematuria, or even massive menstrual bleed itself. So these are the warning signs, right? Next one is organ impairment. As I have already mentioned regarding the liver, there may be transaminitis or transient jaundice, acute kidney injury, that means rise of creatinine more than 0.5 in first 24 hours, or decrease of urine output less than 0.5 ml per hour, kg per hour. So this is very important. This target is very important, the urine output target, right? So this is AKI. CNS manifestation such as encephalopathy may be meningitis, meningoencephalitis or convulsion, seizure itself, obtunded consciousness, right? Next one is cardiac manifestation such as myocarditis, pericardial effusion as a result of the pericarditis, okay? Pulmonary manifestation such as ARDS, acute respiratory distress syndrome, pleural effusion, right? So these are the organ impairment. So if you treat early, if you treat and diagnose early, then the mortality of severe dengue falls below 10 to 20%. But if you are not treating aggressively, then the mortality is as high as up to 50 to 70% itself, right? So you have to identify the diagnosis, you have to identify the organ impairment and treat accordingly as fast as possible. So now diagnosis, about the diagnosis, you all know that the two most commonly used diagnostic tests are NS1 and IgM antibody, right? So NS1 is, I mean, I have already mentioned about the viral structure, virus structure of the virus. NS1 is the part of the virus, right? So NS1 rises within 5 days of fever, initial 5 days of fever, whereas IgM antibody start rising more than after 5 days, right? So NS1 and IgM, these are the most important two diagnostic modalities of this dengue infection. But the gold standard diagnosis is RT-PCR isolation of the virus by NP-OP swab or blood itself. So there are another one is IgG, but IgG, as you all know, IgG stands for the chronic infection. This is not as much as effective for diagnosis of acute infection, okay? So NS1, IgM and the PCR. Definitely viral culture is there, but this is not widely available and this is not accessible, okay? So along with that, supportive investigations. In each and every dengue patient, you have to do complete blood count to see the leukopenia, most importantly thrombocytopenia, and liver function test to rule out any transaminases or any liver failure is happening, kidney injury is happening because of, so you have to send urea creatinine, and hematocrit. You have to look for hematocrit and platelet. These two are the most important things you have to look for, okay? So this is the diagnostic timeline. So viremia starts from day 1 to day 5, and NS1 antigen also just coincides with the viremic phase from the day 1 to day 5. So IgM antibody starts developing from day 5 onwards. So day 5, fifth day is the day that in that phase IgM and NS1 both can be positive in 5th day, and IgG, primary IgG starts developing from day 8 and beyond, and it remains beyond day 14 itself. So now you have already heard about this test, tourniquet test. So what is the utility of tourniquet test? How can we do that? Any idea? How can we do? Any idea about tourniquet test? Any idea? করেছিস কেউ জানিস টুর্নিকেট টেস্ট কি করে করতে হয়? In your physiology class? So first you have to measure the BP, okay? So inflate the BP cuff between the midpoint of the systolic and diastolic BP for 10 minutes, okay? And deflate. So between that, so maintain inflation for 5 minutes and then deflate and wait for 3 minutes, okay? Look for the petechiae. The size, definitely this is important, but you cannot measure that size, right? So if the size is 2.5 into 2.5 centimeter below the antecubital fossa, if in a definite square, if there is more than 20 petechiae, then this is positive, okay? So tourniquet test has low sensitivity but has high specificity, okay? Tourniquet test is a bedside test. Definitely before doing before doing a NS1 and IgM antigen and antibody, you can do tourniquet test to confirm whether this is a not confirm, to suspect whether you are dealing with a case of dengue or not, right? But this is not a confirmatory, okay? So now management, in group A patients, that means mild dengue patients, you can advise home management, adequate fluid resuscitations, okay, antipyretic in form of this paracetamol only, and check for hematocrit and platelet or any warning signs of dengue, but never give NSAIDs, never ever give NSAID, only the paracetamol is enough, okay, and hydration, and never give intramuscular injections, okay, because in dengue there is a chance of thrombocytopenia and coagulation disorder that may lead to hematoma formation if you are giving IM injections. So adequate bed rest and watch for warning signs during the day 3 to day 7. So group B, that requires the hospital admission in group B patients. So the cornerstone of the dengue management is only and only fluid management, okay, nothing more than that, only fluid management. So what are the things we should look for? So you are giving fluid, is it adequate or not? You have to look for that signs, right? One is urine output, this is most important one. Check for urine output, that means that is more than 0.5 ml per kg per hour, this is adequate urine output. Second is hematocrit, fall of hematocrit by more than 10%. Third, it is capillary refill time, okay. Fourth is hypotension, the patient is developing hypotension or not. So these 4 signs are the most important points, bedside clinical signs, that you should assess each and every hour, 1 to 2 hour interval, okay. So first, in case of moderate dengue, IV crystalloids. So what are the crystalloids? Most commonly used crystalloids are Ringer lactates and normal saline. So you can use any of one, NS or RL, okay. 0.9% NS or Ringer lactates you can use in IV form, 5 to 7 ml per kg per hour for the initial 2 hours. Followed by, next you have to assess, I have already mentioned about the assessment. You have to assess after 2 hours whether the urine output is adequate, whether the capillary refill time is adequate or not, and BP is adequate or not. If this is adequate, then you can reduce the fluid by 3 to 5 ml per kg per hour in next 2 hours. And if it is not adequate, then increase the volume by 10 ml per kg per hour. So like that, so 3 to 5 ml per kg per hour in reduced dose. After 2 hours, you can further reduce the volume by 2 ml per kg per hour. After 2 hours, 1 ml per kg per hour. Like that, okay. So the goal, definitely adequate, to maintain adequate perfusion and urine output. Monitor vital signs in every 1 to 4 hours, preferably 1 to 2 hours itself, and definitely look for the severe symptoms, as I have already mentioned, okay. So this is the most important slide, group C category or emergency management of severe dengue. As I have already mentioned, if the dengue is mild, moderate or severe, the one and only management is proper hydration by giving IV fluids, nothing more than that, okay. So in case of severe dengue, as we all know, in case of severe dengue, the hematocrit, primary hematocrit is more than 20% of the baseline because of the plasma leakage, okay. So you have to replenish the volume more aggressively than the moderate dengue, okay. So the initial starting of the fluid therapy will be at a rate of 10 to 15 ml per kg per hour. So that is definitely higher than that of the moderate dengue dose, okay. So remember this chart, this is a very important chart. First, if the patient is having hypotension and severe dengue, Then start crystalloids at a dose of 15 to 20 ml per kg per hour. Look for those signs I have already mentioned: urine output, CRT, BP. Okay, after 1 to 2 hours. Then this is definitely, these are maintaining. Then you can reduce the dose hourly, from 15 to 10 ml per kg per hour. So like that. So 10, 7, 5, 3 ml per kg per hour. Okay. So maximum fluid you can give up to 48 hours, 2 days. So just gradually step down. Monitor urine output, monitor CRT, monitor hematocrit and the BP itself. Okay. So if this is not improving, the BP is not maintaining, the HCT is rising, then what will you do? Then you can shift the crystalloid to colloid form, but this is not the first line. The first line is you have to increase the dose, 20 ml per kg per hour, crystalloid dose. Okay. So if the BP is still not maintaining, you have to switch to colloid. That means albumin, hetrajan or starch. Okay. Right? Understood? So this part. So 20 ml per kg per hour, and definitely you should give a bolus of 10 to 15 ml per kg per hour bolus dose within 30 minutes. That means around 500 ml of IV fluid you have to give within 30 minutes. This is called bolus dose. Then maintenance dose of 15 to 20 ml per kg per hour. And if this is not, if this is the BP is not correcting, you can switch to colloid. Okay. If BP is still not correcting, urine output is still falling, then what will you do? Then you should start vasopressor, noradrenaline or vasopressin. First line is norad. Okay. So this is the guideline. And if the patient is having, along with the hypotension, if the patient's hemoglobin is falling, if it's less than 9 gram per deciliter, then only, and the patient is having active bleeding, then only you should do blood transfusion. Okay. But what are the indications of platelet transfusion? So there are misconceptions about platelet transfusion in case of dengue. So many centers actually transfuse platelet prophylactically, but this is definitely wrong. Only do platelet transfusion if the platelet level is less than 10,000 or at any point of platelet level less than 70,000 with active mucosal bleeding or active bleeding. In only these two scenarios you have to transfuse the platelet, right? Because platelet transfusion actually doesn't correct the coagulopathy itself if the platelet is normal, right? So you cannot do the prophylactic platelet transfusion. So in dengue, thrombocytopenia definitely will happen because this is the pathogenesis of dengue. That doesn't mean you should do prophylactic platelet transfusion. Okay. So these are the indications of platelet transfusion. And fresh frozen plasma or cryoprecipitate if available in case of DIC, disseminated intravascular coagulopathy. Okay. So another one is fluid overload prevention. You have to assess whether you are not doing overcorrection. This is important because capillaries are leaky. So if you are giving more and more fluid that is not required, so the excess amount of fluid will accumulate in the interstitium. That leads to pulmonary edema, right? So that is also important. Correct amount of fluid is to be given or not. That is, so how can we assess the correct amount of fluid? One is urine output, one is CR capillary refill time, hematocrit and CVP, central venous pressure monitoring, or inferior vena cava diameter monitoring. So these all these parameters, that by that which you can assess the volume overload. Okay. So this is the indications of platelet transfusion. When to transfuse platelet less than 10,000, before any invasive procedure, DIC with active bleeding. These are the only three indications of platelet transfusion. So there is a big no of in this prophylactic platelet transfusion, right? And when should you discharge the patient? First, afebrile, HCT is normal, all the parameters, vital parameters are normal, BP is normal, the platelet and the coagulation disorders are settled down. In that case, for more than and at least 48 hours after recovery from the shock in case of severe dengue patients. Only in these scenarios you should discharge the dengue patients. Okay. So these are the differential diagnosis. All viral fevers are the differential diagnosis in dengue. Okay. But definitely in case of chikungunya, unlike dengue, there are more joint pain predominance, less likely in dengue. Definitely arthralgia may happen in each and every case of viral fever. This is a non-specific one. But in chikungunya, this is called breakbone fever. So severe joint pain predominates. Okay, and there may be rash and joint swelling. In malaria, the periodicity of fever along with the splenomegaly, but in dengue there is hepatomegaly. In malaria, predominantly it's splenomegaly. Okay. So these are the differentials. Okay. So in special situations, pregnancy, there is a higher risk of PPH because of the coagulation disorder and thrombocytopenia, and there is a chance of vertical transmission to child, infant, right? So in children, infants with, suppose there is a vertical transmission and the infant is definitely infected with the dengue virus. Further, after 1 to 2 months, infant is again infected with the dengue. So then what will happen? There is a ADE, antibody dependent enhancement, as I have already mentioned in my previous class. So that leads to severe dengue. Okay. In case of comorbidities, just like in case of other infections, diabetes, chronic kidney disease, obesity, these are the risk factors. In these populations, the dengue may become the severe one. So these are your community medicine slides. I am not going into details, right? So NBBDCP prevention and vector-borne control. So I am not going to discuss about this. Okay. This is the important one, dengue vaccine. So this is the talk of the town. So the newest one is this one, TAC 003 or Takeda, that is Qdenga. That is this is the new one. So that is marketed and produced by a Japanese group of pharmaceuticals, and that has been approved by DCGI in recent months in India. Okay. So the backbone of the virus is DENV2 serotype. So there is another one vaccine previously that is called Dengvaxia. So Dengvaxia is different from this one. So Dengvaxia actually, okhane ki hoto, so that Dengvaxia includes the viral components. That means the viral nucleocapsid or viral cell wall. Components of that virus included in that Dengvaxia. So that's why Dengvaxia may lead to antibody dependent enhancement, because there are certain viral components in there. But this is a live attenuated vaccine, and the serotype itself, you are injecting the serotype itself, DNV2. Okay. So this is a live attenuated vaccine. Pregnancy is an absolute contraindication of giving a vaccine, as you all know about the contraindications of live attenuated vaccines. Okay. So there are 2 doses, 0 and 3 months, after 3 months, 2 doses. Okay. 4 to 60 years of population, this age group you can give, right? So this is another national strategy for India, NBBDCP, early case detection, vector-borne management, epidemic preparedness and response, and community activity. So these are the parts of your community medicine lecture. I am not going into detail. These are the pulmonary complications of dengue. I have already mentioned that ARDS, these pleural effusions, and pulmonary hemorrhage rarely in case of severe thrombocytopenia or DIC. Okay. So I am out of my time. This is 10 class ache to. So ठीक है, stop karo. It's very difficult for me to wrap up all these things in 30 minutes, right? So this is a very big discussion topic, right? So in 30 minutes, this is very difficult for me. So I think you have understood all these things, salient features, how to manage a dengue, and right?